Hi there, Dr. Terry Schoenfeld for UAB Department of Medicine. In this video, I'm going to review the perioperative management of adults with obstructive sleep apnea. Several disclaimers: I'm not going to discuss intraoperative management, as that's best left to anesthesiologists. Also, the point of view of this talk is from that of a general internist, so much more complex patients are best managed in consultation with critical care specialists, sleep medicine specialists, or pulmonologists. Finally, the evidence base in this area is fairly limited, but it is evolving, and so many of the recommendations for care that are made are really just based on expert opinion. So I showed this slide in the previous talk on the perioperative evaluation of patients with suspected or with sleep apnea, but I think it's important to review it again. These are the factors that can aggravate sleep apnea, so they'll be the focus of trying to manage these patients perioperatively. Certainly, perioperative medications, especially opioids and sedatives, can worsen airway tone, protective reflexes, and can reduce central respiratory drive. Upper airway narrowing is critical in the pathophysiology of sleep apnea, as is the supine position, and so both of these things can worsen sleep apnea in the perioperative period. Sleep deprivation is very common postoperatively and can lead to something called REM rebound on hospital day 3 or 4, or once the patient's home at day 3 or 4. And REM sleep is a stage at which sleep apnea is most severe, so once they have REM rebound, get more REM sleep, sleep apnea can be exacerbated. And finally, patients' treatment may not be able to be utilized because of surgical issues or nasal tubes, or a patient may have forgotten their CPAP machine at home and can lead to worsening of postoperative obstructive sleep apnea. Now, the critical issues to consider in patients in the postoperative period are oxygenation, pain control, positioning of the patient, and post-anesthesia care unit discharge timing and disposition. I'm not going to talk about this last one just because that's under the purview of the anesthesiologist. Positioning I'm going to mention briefly. As I mentioned on the last slide, supine positioning can worsen the obstruction in patients with obstructive sleep apnea. So if at all possible, try to have patients in a position other than supine, so in the lateral position or in a semi-upright position. I'm going to focus the rest of this talk on issues related to oxygenation and pain control. So optimal treatment of sleep apnea patients really begins in the preoperative period. If patients are already on positive airway pressure, they should continue it up to the day of surgery. It's also helpful if we could get them to lose weight preoperatively to try to help sleep apnea symptoms. But that's obviously a little bit more difficult. If patients aren't optimally controlled and need adjustments to be made, you really need to give it 1 to 2 weeks for these to really kick in and gain maximal therapy. So you might have to delay surgery 1 to 2 weeks after any initiation or changes in positive airway pressure therapy. Now, there are no great surgical studies, but studies in non-surgical sleep apnea patients really do demonstrate that CPAP for more than 2 weeks improves physiologic outcomes. So that's the reasoning behind this recommendation. And it's very important to begin things preoperatively, especially if patients have severe obstructive sleep apnea. Now, all postoperative patients are going to get supplemental oxygen. The key is that the duration that a sleep apnea patient needs supplemental oxygen is going to be very variable and tends to be longer than non-sleep apnea patients. And the importance of oxygen is that it lengthens the interval from when the patient stops breathing to the development of hypoxemia. And we're going to have to wean oxygen at some point. So the way to wean oxygen in these patients is that you're going to monitor their oxygenation. And when they can maintain adequate oxygenation on room air when left unstimulated, that's when you can wean them off oxygen. But you still need to monitor them very closely. Now, it's important to also mention that patients with sleep apnea may have other problems, especially COPD or the obesity hypoventilation syndrome. And it's very important to watch for hypercapnia in this subset of patients. And it's important because these patients are more oxygen dependent for respiratory drive, and supplemental oxygen can reduce their respiratory drive, leading to CO2 retention. So it's very important to keep a much closer eye on these patients than somebody with sleep apnea who doesn't have COPD or the obesity hypoventilation syndrome. If patients use positive airway pressure prior to surgery, we want to try to resume it during sleep as soon as is feasible postoperatively. Now, what we don't know is if it makes a difference or is it beneficial to use positive airway pressure while the patient is awake. And what you want to do is start with their previous levels that their CPAP was set at. And if you don't know, you can empirically start at 8 to 10 centimeters of pressure and then titrate it up till their apneas, desaturations, and snoring are eliminated. So what about patients with sleep apnea who didn't use CPAP preoperatively? Does it help them postoperatively? Well, there's a few studies in this area, and most of them looked at patients with very severe sleep apnea. And what they found was that CPAP initiated postoperatively improved the apnea-hypopnea index and oxygen saturation, but really didn't have any impact on pulmonary complication rates. And one group of experts uses or recommends using CPAP selectively in this group of patients when they develop hypoxemia, obstruction, apnea, or hypoventilation. Again, there's no study to support this, but it was expert opinion. Pain control. Obviously, patients are going to have pain postoperatively. And as I mentioned earlier in this talk, opioids can exacerbate sleep apnea. So an important tenet to remember in treating these patients is we want to try to minimize opioid use as much as possible, use the smallest dose possible, and closely monitor these patients. And we want to try to use opioid-sparing techniques to augment pain control. So one of the things we could use is a variety of other medications like NSAIDs, acetaminophen, COX-2 inhibitors, various adjuvants like gabapentin, ketamine, and clonidine. But we also need to remember regional analgesia. And one thing to remember here, and this includes nerve blocks and epidural analgesia, but with epidural analgesia, you got to remember there can be rostral spread, which can then lead to respiratory depression. So you do have to weigh the pros and the cons here and be in discussions with your anesthesiologist. If patients are on patient-controlled analgesia pumps, we don't want to have a patient with sleep apnea have a basal infusion rate. We only want them to really have PRN infusions as needed, not at a basal rate, so that we have less risk of respiratory depression. And finally, we need to really minimize the concurrent use of sedatives, especially benzodiazepines, because they synergistically act with opioids to decrease the central respiratory drive and inhibit upper airway muscles, leading to upper airway collapse. So if these drugs must be used, you need to really have antagonists close by, so naloxone for opioids and flumazenil for the benzos. It's best to try to not use them at all. So in summary, we need to pay particular attention to oxygenation and ventilation in patients with sleep apnea. We're going to keep them on oxygen until they can maintain their oxygenation while awake and not being stimulated. We want to resume CPAP if they were on it preoperatively as soon as we can postoperatively. And if they have not been on CPAP, we want to try to maybe just use selectively in patients who have trouble with apneas or hypoxia. Pain control needs to be multimodal, and we need to really minimize the use of opioids. And finally, no matter what, these patients need very close monitoring because it's very easy for them to desaturate, and we need to respond to those desaturations in a timely manner.